Yeah. So a warm welcome to all the participants, and a very warm welcome to all the faculties. And for I thank ICS for giving me this opportunity for conducting this webinar today. And I thank you all the faculties for agreeing to be here today, share your insights and wisdom and your experience in the field of tuberculosis. So today we have a special workshop on tuberculosis. We'll be discussing drug sensitive as well as drug resistant TB. We just celebrated World TB Day on 24th of March, and I would say that World TB Day is meant for other faculties, for pulmonologists and specialists working in the field of tuberculosis. It is every day that we celebrate Tuberculosis Day. But today, all the faculties are here to share some exciting new developments. I would say that past decade has been a great decade in the field of tuberculosis. We have had frequent updation of guidelines. We have had new drugs coming in, and now very soon, or I think many of the centers have already been covered with a shorter regimen, which we all have been waiting for. The guidelines and algorithms have been updated, and very soon we'll be having the expert XDR available in the public sector program, and many more new exciting things. So I think it's a great thing to update ourselves with the newer guidelines. And I thank you so much thank you so much Indian Chess Society, Dr. Amita Nene, Dr. Samaria, Dr. Sandeep Salvi for organizing these workshops on a periodic basis, and this has been having a tremendous response. So today we are having one more such exciting session, and we'll start without taking much time. I know all of you are really eager to hear what's happening in the field of tuberculosis, especially DRTB, with all the new guidelines being updated. So I invite the first speaker, Dr. Radha Munje. Dr. Radha, of course, does not need any introduction. She's a great clinician, a great academician, and a great mentor to so many of you. Many of you may have had the opportunity to get the mentorship from her. She's currently the professor and HOD of Respiratory Medicine at IGGMC Nagpur. She's been president of Vidarbha Chess Association in 2019 and 21, and she's been in the governing council of Indian Chess Society for 2 terms. She's been recipient of SN Tripathi Oration at NATCO in 2015, and many more orations through these years. And she's also received the Professional Excellence Award by Government of India on World TB Day in 2021. She's organized 73rd NatCon at Nagpur, and I still remember it was such an excellent conference. I remembered having attended that. And she's been editor of ICS Public Forum, and she's been on the editorial board of many prestigious journals. She's had more than 25 publications and has eight chapters in 7 books. And she's been faculty, and all of us have had the good fortune of listening to her. And today also one such great session we're expecting and eager to listen to Dr. Radha Munje. Without wasting much time, over to you, Dr. Radha.
Thank you, Alpa, for that wonderful introduction. And allow me to screen share the tech team. Okay, is my screen visible?
Yes.
Yes. Good evening, friends, and greetings on behalf of organizers and the Indian Chess Society. Mine is a short presentation, which is MDR TB update And many of the things which I would be talking about are being taken up in detail by the other faculties who would be making a presentation now. So we just have had World TB Day of 2025 with the theme of Commit, Invest and Deliver towards achieving freedom from tuberculosis or NTB. And that is why we are all here committing the time, investing it in a good way, learning about the updates on MDR TB. And what everybody is going to do is when they go back, they would be taking up these strategies in the best possible way for the betterment of their own patients. We all know that this is the grouping of anti-TB drugs which we use for treating DRTB, and these guidelines have come up in 2020, and this is based on the evidence of all the anti-TB drugs used in MDR-TB regime based on their efficacy and safety of second line safety. So when we talk about efficacy, its effect in not only curing but preventing relapses. And when we talk about safety, we have to understand that we are talking about the various ADRs the drug might cause or how efficacious they would be together in rendering a cure to the DRTB patients. So when you look, I have just taken up these diagnostic algorithms. This is for drug sensitive TB, but I'm not going to explain the algorithm to everybody because all of us know. But what is important here to see is that all those who are symptomatic and are suspected of TB, we have to do an upfront CBNAT, which we now call as UDST, that is Universal Drug Sensitivity Testing. So that is the first test which gives you a diagnosis of TB as well as lets you know whether patient is sensitive to rifampicin or rather resistance to rifampicin is detected or not. And based on this, then the further evaluation and the treatment is based on these results. Similarly, when we look at the diagnostic algorithm of extrapulmonary TB, here also appropriate specimen from the site, whichever sample it may be, whether it's a pleural fluid, whether it is a CSF, whether it is an aspirate from lymph nodes, whether it is a pus from the cold abscess, all this, apart from when you send for other biochemical parameters or cytology or histopathology, the second sample or must be taken and sent for upfront molecular testing by CBNAT. And once MTB is detected, it would also give you report upon rifampicin resistance, if any. And at that time, we have to, because these all samples of extrapulmonary TB are very, very precious, it may not be possible to go back and take second sample. When you take the first sample, that time only the second sample has to be preserved for other testings which are needed, either LPA or culture and then doing LPA or DST. There is going to be a talk on diagnostic methods. So I'm not going into the go into the details, but it suffices to say that these precious samples must be preserved for working up further whenever there is a clue to drug resistance. Same is true about pediatric TB diagnostic algorithm. And here also you can see that the samples of either sputum or extrapulmonary TB sites or in children when we take gastric lavage or gastric aspirates, all must be subjected to molecular testing or doing CBNAT. And then you look at the reports, and if RIF resistance is detected, and even if RIF resistance is not there, but the organism is seen, further cascaded diagnosis must be made into the relevant laboratories. Now, this is the recent integrated diagnostic algorithm that we have. And here you can see what I have already said, that all notified TB patients, those who are not offered to see for RIF resistance, like a diagnosis is made only by looking at the sputum smear or only by looking at the cytology or histopathology in case of extrapulmonary TB. That sample, you have to collect two specimens and test for resistance to not only rifampicin but also rifampicin and INH by doing first line LPA, and fluoroquinolones and other injectables by doing second line LPA. Now, whose samples would you be taking? All notified TB patients, all presumptive TB cases, that is those who are symptomatic and we are doing the first time workup, as well as all those who have taken treatment in the past and have either responded or even not responded. So non-responders to any regime, whether it is DSTB regime or DRTB regime, all non-responders must undergo molecular testing in the laboratory by line probe assay for first line and second line drugs. If you detect MTB positive and RIF resistance is detected, the recent thing which has come up and has modified this diagnostic algorithm is that as soon as RIF resistance is detected, you have to look for eligibility for B-PAL-M regime and offer B-PAL-M regime if we find that the person is eligible to take that regime. If the person is, I'm not talking about eligibility right now because it would be taken up ahead. If the person is not eligible for B-PAL-M, then you have to assess whether a person is eligible for shorter oral regime. Now, this shorter oral regime has been there since 22. If so, then they get a shorter regime of 9 months treatment, which contains the 5 drugs of bedaquiline, levofloxacin, linezolid, clofazimine, ethambutol, and high dose of INH. If the person is not eligible for even this shorter oral regime or any other additional resistance is detected during treatment or when the treatment is initiated or soon after, then patient goes to modified longer oral regime and drug replacement to be done as per replacement table. So this is what is there which is being done. However, when you do a molecular testing and MTBR resistance is not detected, the sample goes to the laboratory and LPA is done. And in first line LPA, if INH resistance is detected, the patient is offered 6 to 9 months of INH monoresistance treatment. And if additional resistance is detected, then it has to be modified as per guidelines. And if your patient is lucky enough not to have any of these resistance, of course, he gets the DSTB regime of 6 months of 2 months of INH rifampicin, pyrazinamide and ethambutol, followed by 4 months of INH rifampicin, ethambutol. Here it is important to see that INH resistance is also ruled out whenever rifampicin resistance is not detected. So I have already explained, but if you go one by one, you would see that the sample has to be sent for first line LPA to the higher laboratories because at DMCs or diagnostic centers, only TrueNat or CBNat machines will be available. Whereas for LPA in the program, as well as even in practice, all microbiology laboratories may not be equipped with LPA. They may have CBNat, they may have CBNat ultra machines, but may not have LPA. So you have to, or culture facilities may not be available. At that time, you have to select a laboratory where all these facilities exist. Then there are some criteria like you have to, the presumptive TB, this is an explanation of what I have already explained and the diagnostic algorithm. That TB patient's diagnosis is based on smear microscopy, many times clinico-radiological assessment and histopathology. However, all these patients must be encouraged to give a sample taken either by gastric aspirate or bronchoscopies or relevant investigations to be done, and sample is to be sent for molecular diagnostics. And presumptive TB are always those who have chest X-ray abnormality suggestive of TB with or without symptoms. And all of these must undergo the sputum examination. Other types of samples, as I have said, are already known that it can be gastric aspirates, bronchoalveolar lavage, fine needle aspiration, cytology of peripheral lymph node, CSF, and other signs. So this diagnostic algorithm, I have already explained in which way it goes forward. So I'm not going to revise, but it suffices to say that the recent guidelines say that as soon as rifampicin resistance is detected on molecular test, apart from sending the sample ahead for first line and second line LPA as well as cultures, assess the patient for eligibility of BPAL-M regime, and if the patient is eligible, patient would be getting BPAL regime. If not, then I'm not audible. Okay. And if MTB resistance is not detected, then I have already explained about INH mono resistance regime and DSTB regimes. So what do we have in the guidelines are, we have 6 months shorter oral regime, which is BPAL-M. And this is what is the recent update that we have in programmatic management of drug-resistant TB. The 9th month shorter oral MDR or rifampicin-resistant TB regime remains, but it is for all those who cannot be included or given BPAL-M. And all those who cannot get, for when you apply the inclusion exclusion criteria, and if they are not eligible for BPAL-M or shorter, then they go for longer oral MDR or XDR TB regime. Whenever this slide I have placed here, and I'm sure one of the faculties would again be showing this, but why I have kept it here is that it is for you to understand that as soon as your molecular diagnostic report comes as rifampicin resistance, it would be another few days by the time you get LPA reports. But you should not wait to get LPA reports, and you can start with the pre-treatment evaluation, which is needed for these MDR TB patients. At the same time, we have different pre-treatment evaluation for eligibility of BPAL-M also, and I'm sure KOMAL would be talking about it. In short, pre-treatment evaluation consists of CBC, blood sugar, blood urea and creatine, that is KFT, audiometry only if an injectable is needed, but if patient is going for BPAL-M, audiometry is not needed. Liver function test, urine examination. If the patient is to be put on a regime where cycloserine is there, then psychiatric evaluation, serum electrolytes, ECG, urine pregnancy test, ophthalm opinion, and surgical evaluation. If at all you think that the patient might need something to be done in the future, you can do that or you can skip that. Here is an eligibility criteria for BPAL-M. It is to be offered to age more than 14 years and above, new microbiologically confirmed RATB person, and if at all they have taken bedaquiline or linezolide, then it should not be, the exposure should not be more than 1 month. If the exposure is more than 1 month, then you need DST of all these drugs in BPAL-M. Then there are some exclusion criteria for BPAL, which I'm sure the other faculty who is making a presentation of BPAL-M would be doing that. So I'm not reading this, but we have to understand that even if we want to offer BPAL-M to our patients, there are stringent inclusion exclusion criteria which must be followed, and then only you offer the regime which is available in PMDT. So this is in short about the update that we have for PMDT. I have ended my presentation, but this is a new beginning for the PMDT program in our country. And my talk is over. Thank you for patient listening.
Thank you so much, Dr. Radha. That was an excellent talk and very concise and to the point, telling us about the new guidelines. And the very clear message is now first preference for DRTB patient would be the shorter regimen, and we must know the inclusion and exclusion criteria, and those who cannot be given BPAR regimen would either be given all oral longer regimen or shorter regimen. It was an excellent presentation, Dr. Radha. Thank you so much.
Thank you, Alpa. And before we go ahead, can I take a pleasure of introducing our host and moderator for today, Dr. Alpa.
Thank
Dr.
you.
Alpa Dalal is a consultant pulmonologist with Jupiter Hospital. She has an experience of more than 30 years in treating DRTB patients. She is an expert in DRTB treatment and has been counted as national expert and is always there on the ECO platform whenever we deal with difficult to treat TB clinics. And Alpa is also associated with Sewree TB Hospital. And apart from whatever work she's doing as a pulmonologist and as TB expert and offering DRTB services, even in private sector, she offers her services in the public sector also. And she believes in holistic approach towards management of her patients, be they TB, be they DSTB or DRTB. And each of the patient who goes to her is super happy when they come out with a great confidence to continue treatment and get cured of TB. Alpa, I
Thank you.
think you should take ahead.
Thank you so much, Dr. Radha, for that kind introduction. And
And yes,
now we'll
she's a wonderful friend of mine. And I have been fortunate enough to interact on various platforms with Alpa.
thank you so much. So now we go over to the next talk, and that's current TB diagnostic landscape. And the next speaker is Dr. Bharti Malhotra. So let me have the pleasure of introducing Dr. Bharti Malhotra. So Dr. Bharti Malhotra, she's a senior professor of microbiology and ex-additional principal SMS Medical College, Jaipur. She's ex-president of IIMM National and Rajasthan chapter, founder and vice president of IIM Rajasthan chapter. She's also been a nodal officer at DHR State Virus Research and Diagnostic Lab, ex-Dean Medicine Rajasthan University of Health Sciences and ex-professor and vice chancellor of ex-pro vice chancellor of Rajasthan University of Health Sciences and ex-treasurer IIM. So apart from that, her major achievements have been she was first to start the molecular diagnostic lab in the state, and
Maybe you can just skip that. Let me try and share my screen. That's just for the presentation. So
yes.
just let me see how I can share my screen.
So I think I won't waste much time, and then she's, as you can see, she's been, doing very pioneering work in the field of microbiology, and we are all eager to listen to you, madam. Over to you, Dr. Bharti.
Can you allow me the screen share? So this is I bring greetings from SMS Medical College, Jaipur, my alma mater, where I'm a senior professor in microbiology department. And the overview of my talk would be introduction, smear microscopy, immediate culture, WHO endorsed TB diagnostics, low complexity NAT, automated and manual, the moderate complexity automated NAT, line probe assay, targeted next generation sequencing, and the performance characteristics and recommendations. So I'll be quick because the time has been reduced to 15 minutes. So we all know about the TB, and we have already heard Dr. Radha's talk, and I'll be skipping this introduction. We know very well about the TB and the DRTB burden also. We very well know, and we know the importance of the TB diagnostics. Over the period of time, they have really transformed the diagnostics have transformed the how we are treating the TB, and we are now moving towards eliminating that. So, of course, though WHO doesn't really recommend smear microscopy, but in our country, we're still using the smear microscopy, the ZN staining, the rhodamine, and now we are also doing the fluorescent diacetate for detecting live bacteria at an early stage and monitoring the ATT response. There is automation in staining, and AI is also being used to do the interpretation. So we did a study on FDA versus LJ, and we found that the sensitivity was 80% for FDA versus LJ, and specificity was 85%. So it seems to be a good tool on the site in periphery, where you can at least have an idea whether the AFB you are seeing are viable or not, and particularly useful for the follow-up of the patient. So the WHO endorsed TB diagnostics, we have low complexity automated NAT, for detection of TB, like Expert RIF and Expert Ultra, and the TrueNet MolBio. And then we also have the low complexity manual net for TB lamp by the Icon company. And then we have moderately complex automated NAT for detection of TB and RIF resistance and INH. That is Abbott Real-Time MTB and Abbott Real-Time MTB RIF INH. Then BD has also come out with the platform, which is MBD Max MDR TB. It can detect INH and rifampicin. There is COBAS, which is detects MTB as well as MTB and RIF and INH. And there is fluorotype MTB DR, fluorotype MTB that can detect both MDR as well as MTB. And this is, if you can see, this is the Roche COBAS 8800, which we have in our lab. And at the COVID time, we could do 4,000 tests a day. So it has a massive capability of a large throughput. Then BDMAX has a good capability, can be placed in periphery, and can do INH as well as rifampicin. Then there is low complexity automated NAT for detection of INH and second line DST. The MTB XDR from the CIFID can do the XDR also, and the line probe assay, the genotype MTB DR +1 version 1 and 2, and the MTB genotype MTB DR second line assay can do for the second line assay. And there is GenoScholar, which can also do the NTM and MDR-TB. Of course, the line probe assay by genotype also has an NTM assay where you can differentiate the NTM. Now, talking of the low complexity automated NAT, we have MTB RIF CIFID. It is very extensively used in periphery and in the referral labs. It can detect MTB as well as rifampicin resistance. And the important thing is that it detects within 2 hours time, and it is being done at the district and sub-districted level. Uninterrupted power supply is the main key issue here. For that, later on, and this is what the principle of this test is. I'm not going into the details of that. Then the recommendations are for the adults and the children with the signs and symptoms of pulmonary TB, and for the tubercular meningitis, and also for the extrapulmonary TB. Then there are low complexity automated NATs, the MTB RIF Ultra. This is the next generation test, and it has higher analytical sensitivity. The limit of detection is 16 CFU per ml versus 114 of the earlier, only the MTB RIF. And it can detect 2 different multi-copy amplification targets, IS6110 and 1081. It has larger DNA reaction chamber, so the volume also you are adding is more, so the sensitivity is much more, and it has improved the accuracy of rifampicin resistance. So the recommendations again are for the pulmonary TB patient with signs and symptoms of pulmonary TB, for the children, the nasogastric aspirate, as well as it is also being used as the initial diagnostic test. It is definitely the similar recommendation as compared the earlier version. It's only more sensitive. And then we have these low complexity automated NATs like TrueNat, which is our indigenous and much cheaper and is very robust. You can use it without the electricity. You can just use the main thing is that doesn't require the air conditioning. For CIFID, like if the room temperature is not okay, that there are errors in that system. But with TrueNat is very robust in Indian setting and can be comfortably used. And it is made in India, chip based, and the TAT is again 2 hours, less than 2 hours, and it is battery operated, used in the peripheral labs, and but it has multiple pipetting steps as compared to the Gene Expert. That is the limitation of the test. So the technicians are happier with the CIFID. It's easy to use, but not so robust in without AC. TrueNet MTB plus as well as the MTB RIF DX, it's being used for the adult and children, and the sputum as the initial diagnostic test, not yet been recommended in the extrapulmonary. This is the photograph of this TrueNet or the MolBio. Then there are other low complexity manual NATs like LAMP assay, which is made by the Icon, or it's a Japanese firm. It is only for MTB detection. It doesn't have the DST facility, and it was endorsed in 2016. It is manual assay, and it is being used in the peripheral labs. It is recommended for the adults with the pulmonary TB. Therefore, the sputum may be used as a replacement for microscopy, and initial smear negative follow-up tests. So this is how the lamp assay looks like. The kit is there, and below you can see that the colored green fluorescence, and that indicates it's a positive test. So if you look at the performance characteristics of all these assays, we find that MTB-RIF, it has a sensitivity for MTB detection as 85 versus in 90 for the Expert Ultra. And for RIF resistance, the sensitivity of MTB-RIF is 96 as compared to 94 for the Ultra. And the TrueNat MTB plus the sensitivity is 80 and MTB-RIF is 84. And LAMP assay is 878. So, but the important thing is that you can use the TrueNat in the peripheral labs. The LAMP assays are also being used in the peripheral labs. All the TAT is for all these assays is less than 2 hours. So that is the beauty of it. So WHO, of course, recommends to replace the smear microscopy with all these tests, but we are still in the process of doing both the tests. So there are moderate complexity automated NATs in the high burden Isonex rifampicin resistant and for the rifampicin sensitive TB, which mostly goes undiagnosed if you're not looking at the Isonex resistance initially, because the gene expert and the TrueNat, they are not doing the Isonex resistance. So that is a major gap in our system. So now we have these faster and less complex assays to perform, mainly being run on the multi-disease high throughput platform, which are already existing for HIV, HCV viral load, like the Abbott is there, and the BD Max also can do it. So they have automated or manual DNA extraction, and everything else is automated. But the setting is generally the referral lab till now. But whether the program is going to place them in the periphery, because they are higher throughput, so the chances of place them in periphery are less because of the higher throughput capacity. So they are again recommended for people with signs and symptoms of pulmonary TB, for the respiratory samples, and they are being used for INH and rifampicin resistance together. So this is how the Abbott looks like. This is how the fluorotype MTB-DR system looks like. And then this is we also have the CIFID, which does the low complexity, which is the XDR assay, that also is categorized as low complexity automated NAT, because it is the MTB-RIF doesn't do INH, but this MTB XDR does the INH as well as the second line anti-TB drugs. Though it's not come into the program yet, but CIFID is marketing it, and it can detect mutations to Isonex, fluoroquinolone, ethionamide, and second line injectable drugs like amikacin, kanamycin, and captomycin. It has 10 color technology, so the older platforms cannot detect these, run this assay. You need the later version of the Gene Expert platform, which has 10 color technology, and then the assay needs to be updated quickly, because now with the introduction of bedaquiline, linezolid, this assay cannot detect these drugs, so that needs to be updated. So the low complexity NAT detection, it is being recommended again in pulmonary TB, sputum samples, and where we have the initial resistance to Isonex and fluoroquinolones. Then bacteriologically confirmed pulmonary RIF resistant TB, there also, if you can do the initial resistance to ethionamide and amikacin, can be seen. And then there are line probe assays. These are very commonly used in the referral lab setting, and we have a solid network for that. They are reverse hybridization DNA technology based. They can detect MTB and the drug resistance profile. And there is a binding pattern, which I'll show you the picture of, where you can look at the pattern and do the interpretation of the drug resistance. So that has steps of DNA extraction, multiplex PCR amplification, and reverse hybridization and visualization of the bands. So this is the principle of the test. I'm not going in details. So there are first line and second line assays. First line assays for the rifampicin, there are pubio genes and high level Isonex and low level Isonex resistance by CATG and INHA promoter genes probes. And the second line probe assay for fluoroquinolones, it has Gyrase A and Gyrase B probe, and for second line injectables, it has RRS and EIS probe. And by looking at the combination of these, you can do the interpretation of the resistance. This is how the INH MTB-DR plus probe. These are the probes which are on the MTB-DR plus line probe assay. For that is the first line, and this is the second line probe assay mutations in the probes. So which is routinely used in our labs and all the culture DST and the IRLs of the NTEP. So they are recommended for smear positive or the culture isolate, and they can first line can detect INH and rifampicin. So this is used as the initial test. Generally, we do the gene expert, and then we are doing the line probe assay. Once that is coming positive, and then second line assay are used if there is MDR. Only in the cases of confirmed MDR, we are doing the second line probe assay, and the sample has to be either smear positive or the culture isolate, and you can detect the resistance to quinolones and second line injectable test. Then if you look at the performance characteristics, the line probe assay, the sensitivity for rifampicin is 98%, and for INH it is 84%, and for the second line injectables it is 86% for fluoroquinolones and 87% for second line injectable drugs. How we are doing each test, I'm not going to do the diagnostic algorithm because Dr. Radha has already dealt with it, and others are also going to deal with this. I'm just sticking to my topic. So now we have this, a lot of buzz is there about the targeted next generation sequencing. Dr. Siva is doing a whole lot of gene sequencing. Of course, there we have two types, the whole genome sequencing as well as the targeted next generation sequencing. I'm only talking of the targeted next generation sequencing because this is cheaper and quicker to perform and easier to do, and you can do it on the sputum sample itself. You can do, it is amplification of selected genes followed by NGS. It detects resistance to many drugs with a single test. The entire gene is, you can see the specific mutations which are associated with resistance, and it can also look at the resistance to new and repurposed drugs. It has great potential for comprehensive resistance detection, but it is expensive and you need the knowledge of the targets. And this is how the flow is, that DNA extraction is done from sample, do the multiplex PCR, the deep sequencing is done, and you look at the analysis done by the clause-based analysis, and then visualization and reporting is done. So we have Dplex micro TB kit, which has a large panel of drugs. The Iron Torrent platform also has a kit, but the panel of drug-resistant genes is very limited. So that is not being recommended, not being used routinely. And the whole genome sequences, sequencing requires a culture isolate and takes longer time to do it. And then first you have to culture, and then again it's a cumbersome process. So it is the targeted sequencing which is being routinely used. So it is for the bacteriologically confirmed pulmonary TB disease cases, and it can detect rifampicin, Isonex, pyrazinamide, ethambutol, fluoroquinolone, bedaquiline, linezolid, clofazimine, amikacin, and streptomycin drugs. It can detect resistance to these, and so it is being used currently. And Dr. Siva may be telling you more about it. He's been doing for the whole of the country, and he has a good database, especially the Indian database is there with on their website, and you can see what mutations are common. So another thing which I'm going to touch about is latent TB, because that is now again the program is looking at detecting the latent TB, and then active screening is being done. So we have tuberculin skin test. I'll just briefly cover this, and interferon gamma release assay. And in interferon gamma release assay, we have quantiferon TB gold in tube test, that is QFT, and then we have spot TB test, which or the T spot, and you are looking at the cells producing the interferon gamma. The interferon gamma release assay, it is in vitro blood test. It measures the well-defined mix of synthetic peptides, the TBT 7.7, ESAT6, and CFP10. We have two types of assays, quantiferon TB gold and the spot TB test, and there's another quantiferon gold plus. In this new test, you can do both CD4 as well as CD8 responses can be seen. And then there is another Psi TB test, which is specific for antigen first. It's a skin test, and it is being made by Staten Serum Institute. Now they have given the Serum Institute of India the rights to make it, and then it has the ESAT6 and the CFP10 antigen in it, and it is a skin test. It's being tried in the children with TB. So this is what the details about the quantiferon and the T spot test, how they are detecting it, the principle behind it. Important thing is when you look at compare the TST and the IGRA, you see that the TST has the specificity is low, but the sensitivity is high, and it is easy to use, and the cost is low. And it can be used in the children, and people living with HIV will not give a correct interpretation because of poor immune response. IGRA has higher sensitivity, high specificity. It is now being used and recommended by the program, the quantiferon gold plus assay, but it requires a lab and the cost is higher as compared to the TST. But now the program is looking at active case finding. And so whom to test for latent TB? The children less than 5 years, more than 5 years of age, and adults with pulmonary high risk population has to be tested, and other high risk group also to be tested as per the diagnostic algorithm. So this is another test.
Overshooting the time, so
Yeah, I'm done with it.
Okay.
Yeah, no. So what we need is we have good landscape of TB diagnostics which are accurate and faster. We have NAT, which is giving good clinical impact, and the reduction in time is there. And now it has been helped in treatment. And what is needed is that active case finding is what we are looking at. We are looking at rapid molecular detection of MTB and MDR-TB, and initiating like BDMAX and COBAS, and all these newer platforms are being tried. Contact tracing and screening and initiation of TPT is being done. Monitoring of response and early detection of MDR, XDR using the NGS platform, and personalized treatment regime. That is the way for the future, and that is what we are looking at in the future, very immediate future. Thank you so much for.
Thank you, Dr. Bharti. That was an.
Thank you.
Thank you so much. That was an excellent talk, very comprehensive. I wish we had more time. We could have covered it more elaborately, but that was excellent. So I think now we go to the next talk, and that is BPAL regimen and role of Bedaquiline in DST. And our speaker is Dr. Siva Kumar. So can I have the introductory slide of Dr. Siva Kumar?
Okay. So before starting the talk, I am Siva Kumar from the National Institute for Research in Tuberculosis and from the Department of Bacteriology, presently heading the department, which is also a supranational reference laboratory. I'm also a WHO technical advisory group member in laboratory diagnosis of tuberculosis. Apart from that, the lab is a WHO pre-qualification laboratory. I'm also heading that. So, not going further on it, the topic given to me was BPAL regimen and role of BDQ DST. So I'll be mostly concentrating on the data on BPAL regimen and the role of BDQ DST, how it is done, and what are the newer methods which are available for DST of bedaquiline and other drugs which are part of BPAL regimen. So the whole regimen started with the NICS TB trial, which had the BPAL, not the MOXI part of it, which gave. Yes.
Are you having slides, Dr. Siva Kumar?
Sorry.
Your slides are not seen.
Oh, sorry. Okay, it was not shared. I don't know why. Okay. Are you able to see my screen now?
Yes, we are able to see the screen now.
Yeah. So I'll just start from this slide. So the whole BPAL regimen started with the NICS TB trial, which gave a 92% favorable outcome at 6 months post-treatment with the combination of bedaquiline, pretendamide, and linezolid. Linezolid at a concentration of 1,200 milligram. Though it had some side effects, but then WHO recommended BPAL with 1200 milligram of linezolid for MDR TB in 2020. But then since linezolid at 1200 milligram was little causing peripheral neuropathy and myelosuppression as well, in the Zenic TB trial, the concentration of BPAL was reduced from 1200 milligram to 600 milligram for 26 weeks, and at the end of 78 weeks, sorry, for the 26 weeks and the 78 of post-treatment follow-up showed a reduced what you call adverse events. But then in the BEAT study and the study which was conducted by NIRT, that is modified BPAL, which included even 300 milligrams, showed equivalent outcome to the normal BPAL regimen. So that could also be used. So, but then that was not included in the present regimen. The present regimen has these drugs, which are the all oral BPAL M regimen, which consists of bedaquiline, which is a diaryl quinolone antimicrobial that targets TB bacteria by inhibiting ATP synthase. Pretonomide, which was recently approved by FDA, nitroimidazole, a drug that it disrupts TB bacterial cell wall by inhibiting the synthesis of mycolic acid. So one is ATP synthase inhibitor, one is mycolic acid synthesis inhibitor, which doesn't allow the formation of proper cell wall so that bacteria is not live. Then linezolid, which has been used previously for a lot of other infections, which is a oxazolidone. It inhibits the protein synthesis and have a dose-dependent toxicity as well, so which we have seen. So as you reduce the dose, it can be riped well for any infectious diseases, especially for tuberculosis. So apart from that, moxi is added, moxifloxacin, which is a fluoroquinolone that enhances bacterial activity by inhibiting DNA gyrase, and it also prevents bacterial cell DNA and RNA synthesis. So I mean, what is the load of people who require this regimen? So if you look at India TB report, in 2023, DSTB was around 24 lakhs and DRTB was around 86,000. Out of that, MDR TB or RRTB who are eligible for BPAL regimen could be around 63,000 people. So that's the load of a burden of MDR TB, which have to be treated with BPAL regimen, and a longer regimen is not showing that much of a good outcome. Using BPAL regimen in a shorter study which was recently conducted without M, it showed a outcome of around 92 to 93% in all the arms with different dosage of linezolid. So this my previous speakers have already talked about, but this is just to emphasize. It's an integrated diagnostic and treatment algorithm for drug resistance TB, mainly when BPAL M regimen has to be considered. It is clearly divided into two parts. One is right and one other is left. On the left, you have MTB resistant strains or MTB patients who are resistant to rifampicin. And if they are greater than 14 years, they are eligible for BPAL. Otherwise, they go into the longer and shorter oral regimens as per the workup. So if a patient goes to a BPAL regimen, then he takes for the first 2 weeks he takes 400 milligram once daily, which is 4 tablets of 100 milligram tablets, along with pretonomide 200 milligram, linezolid 600 milligram, and moxifloxacin 400 milligrams single tablets. And this then bedaquiline is changed to 200 milligram thrice 3 times per week as 200 milligram dosage, and this might be continued to 29 months depending upon the treatment follow-up, and can be continued to 39 months in case of pretonomide, linezolid, and moxifloxacin, depending upon the workup of follow-up of the patient and his response to the treatment. Apart from this, pyridoxine will be administered for entire duration of treatment as per the weight band. Yeah. So coming to my part, so so before introducing bedaquiline, there were a few things which bedaquiline and BPAL regimen, three things which we have to take care. What is the basal level resistance of these drugs in MDR TB patients? Because the intent to treat this patient are MDR TB patients. They are not DSTB. We are not introducing this into DSTB. So if you look at baseline resistance in the previous MBPAL study, it was around 2.17%. And for linezolid, it was 1.4%, and pretonomide, it was little higher. I'll tell you about pretonomide in the next slide because it has a different variability. If pretonomide concentration is, the testing concentration for pretonomide is 1, then the resistance is higher. I'll talk about it later. But then BDQ resistance in various studies, other studies by Dr. Ajay Veer, and have shown a percentage of 1.64, and this frequency is higher in patients who are treated, which is around 7.14%. But then in some areas of DRTB patients, it has been shown that out of the 117 BDQ exposed patients for our last 2 years, and have shown increased BDQ resistance, which has gone up to 36%. This paper was published by Dr. Singla et al. In 2025. So this is the basal level resistance or to various bedaquiline, various BPAL regimen drugs. So particularly on pretonomide, it is very in a study by us at NIRT has shown that pretonomide shows increased MIC. That means it needs little more concentration of drug to get killed for a particular lineage. So the green bar represents the lineage 1, and the orange, I'm little poor in color coding. So orange color one, which represents the other lineages, which is 2, 3, and 4, show inhibition below 0.5. What does this mean? Is like lineage 1 has requires little more drug to be killed, okay, and other lineages require less, that is 0.5 and less, whereas lineage 1 requires 2 and above. So previously the critical concentration for testing for pretonomide was decided using NICS trial as 1. So if you keep 1 as MIC for or critical concentration for the drug, there are high chances that all these 38 strains which are here, I hope you are able to see my pointer, and these 3 strains all are labeled as resistant. So with this data and other data which is available world over, WHO has changed the critical concentration of pretonomide to concentration. One is at 0.5 and 2, so that you can cover the whole thing. So this increase, you might be asking me why this increase is maybe due to intrinsic resistance, but actually we didn't find any specific mutations which leads to resistance to these drugs. That's why there are 2 concentration, and a few studies on treatment outcome also have not shown very great difference between these 2 lineages, although the numbers were very less. So India has a good proportion of lineage 1. So if there is some kind of a failure on it, this also can be failure of a patient. This can be considered and looked for when you are really looking at pretonomide resistant strains. So going to the challenges in conducting DST or drug susceptibility testing, first thing is availability. If you look at any point of time 3 months before, bedaquiline DST was only done in 5 places all over India, 5 to maximum 6 places. And as I told you, the load was around 63,000. So it is quite difficult to do BDQ DST for 63,000 isolates in around 6 labs. So now with the introduction of BDQ and the strong decisions taken by Central TB Division, there have been another 33 labs which have been trained, and this trained labs is going to offer uh, testing to bedaquiline, pretenamide, as well as linezolid for all the BDQ containing regimen. They are under certification now. Maybe in a month's time, all of them, 1 month's time or 2 months' time, it will be done, and they will be able to offer BDQ as well as other drugs of BPAL, comprehensive DST. But then DST takes time. So turnaround time for phenotypic DSTs, particularly for microbe dilution assays or for midget containing assay, it's quite time consuming. And genotypic methods can be faster, but then we don't have rapid genotypic methods which are available now. So another problem with bedaquiline and other drugs as well, the mutational variability, where mutation in ATP gene is considered the most common reason for drug resistance, but in Western isolates as well as other South African isolates. But then if you come to India, then the resistance mechanism is due to a efflex pump, which is RV0678. So that's the most common mutation which is seen for bedaquiline resistance. So this also depicts the same challenges. Phenotypic DST takes for culture around 42 days, and after 42 days, again another 15 to 20 days for phenotypic DST, which takes close to 6 to 9 weeks for any DST to be available. And for this, you need to have a culture to be grown from the sputum sample. So phenotypic DST is definitely time consuming, but then it gives you answer to all the BPAL regimen drugs. The second thing which can be used is whole genome sequencing. So before going to whole genome sequencing, I just want to break a myth that next generation sequencing is a technology by which you can parallelly sequence a lot of full genome of a bacteria or full genome of a human in a very good sensitivity and specificity in terms of that is the NGS creates multiple copies of a particular genome, so that when you call a mutation, that mutation is called at a very good accuracy level. So that's next generation sequencing. Through next generation sequencing, we can perform whole genome sequencing. That is, you take the whole genome of mycobacteria and sequence it, and you get a genome of mycobacteria, and with multiple copies of genome of mycobacteria. So that is whole genome sequencing, wherein the whole gene of a mycobacteria is presented there.
So, Shiva Kumar, we have about 3 minutes more. We have to complete.
Yeah, I'll be able to complete. So, okay. That's whole genome sequencing. And so targeted sequencing. Now, if you are looking for drug resistance, whole genome is helpful, really helpful to detect newer mutations. But then if you know the targets, you can do targeted next generation sequencing, which is another method of next generation sequencing, wherein you can directly do it in sputum sample. Now, so this is about next generation sequencing, and I have told you WGS is generally performed on strains grown in culture, and they relatively require good quality of DNA, and attempts to directly do it on sputum has not given good results. So, okay, so what is the answer? Answer is targeted next generation sequencing, wherein you can do sequencing using even a DNA which is extracted from TrueNat, and this can give you results within 24 to 48 hours. And this can be directly done on sputum sample or any other extrapulmonary samples with higher load of bacteria. This can give you more than 15. Now we have designed till 18 drugs. It gives you lineage, it gives you polytyping, and it gives you mixed infection if there is NTM infection, or it also speciates NTM into different species, close to 120 species. So what is required for accurate calling is the mutational catalog, that is mutation which leads to resistance, not the ones you don't take into account the other mutations which doesn't lead to resistance. So so that kind of a mutation with resistance has been cataloged, and that catalog has been developed by WHO, as well as Indian catalogs have been developed, and this is getting trained now as a master to get a proper results from TNGS and whole genome sequencing. So this is one of the study which is published for targeted next generation sequencing. You can see that most of the drugs show above 80-85%, except for clofazimine, linezolid, and bedaquiline. That is because the number of resistant strains have been very less, although the duplex test shows a better resolution. So the whole idea is to introduce this TNGS for the management of BPAL regimen. So it can be introduced after gene expert, where second sample can be collected, and this second sample can be cultured, as well as targeted next generation sequencing can be done in all the LPA labs. That's what is expected. Thank you.
Thank you so much for that excellent, insightful talk. It is a blessing for clinicians to hear from the scientific angle. And thank you so much, Dr. Siva Kumar. That was excellent talk, and targeted new generation sequencing is really looking excited, and we all clinicians hope that we'll be able to have access to it much sooner. Now, going to our next talk is on different regimens available for treatment of DRTB. We have Dr. KOMAL Shah with us, our young dynamic pulmonologist from Nashik. She's an associate professor in Department of Pulmonology at Vasantrao Pawar Medical College, Hospital and Research Center. And she's also infectious disease specialist. She did her training, DNB training from Jaslok Hospital, and she's also done her fellowship in infectious diseases. And she has been awarded many best paper awards, as you can see here. And I'm sure she's going to give a very, very great talk on different regimens available. So we already have had some discussion about it in the previous talks, but we'll know more in detail about it. And what I would request Dr. Komal, if whatever has been discussed earlier, in the interest of time, maybe we could rush through. And anyways, we are going to cover those things in the panel discussion. Thank you so much. Over to you, Dr. Komal.
Thank you, ma'am, for the kind introduction. And I would like to thank ICS. This is visible, right?
Yes, it's visible.
Is it? Yeah, one second. One second. Yeah, I know that, but there is some issue here. 1 minute. Yeah. Yeah. Can you see it now? Yeah, 1 second. Yeah, so good evening, everyone. And first of all, I'd like to, it's not moving. The slides are moving. So I'm not able to move the slides.
Have you put it in the presentation mode?
Yeah.
Yeah, now it's good.
Yeah. Okay. So first of all, I would like to thank ICS for giving me this opportunity, and we've had a wonderful series of lectures before this. So in the interest of time, as Alpa ma'am said, I'd be brushing through some talks which have already been covered, but we'll discuss in detail about BPAL, shorter, longer, and other H monopoly regimes. So I'd like to start by saying that to me, TB is like worst girlfriend ever. It will never leave you, and you cannot even choose which regime to start. My slides are seen, right? Yeah. So types of drug-resistant tuberculosis are, we all know about it. I'll go quickly about this. Isoniazid resistance, rifampicin resistance, MDR, 3-XDR, and XDR. So only if there is only isoniazid resistance, it will be H mono or polydrug resistance. If it is only rifampicin resistance, it will be RR, rifampicin resistance. If it is rifampicin plus isoniazid resistance, whereas other drugs are sensitive, it will be MDR. If it is rifampicin isoniazid plus any of the fluoroquinolones, it will be pre-XDR. And if it is rifampicin isoniazid, any of the fluoroquinolones plus either of the bedaquiline or linezolid or both, then it will be XDR tuberculosis. So these definitions we must know so that we can treat them further better. So now the second line TB drugs are divided into three groups. First is group A, that is LLB. I remember it like that: levofloxacin, linezolid, and bedaquiline. Group B is clofazimine and cycloserine. And group C is ethambutol delaminate 1C. Pyrazinamide, imipenem-cilastin, amikacin, ethionamide, and PAS. Again, I'm not able to move the slides. Okay. So when we look at the options for treating this DRTB, we have basically four options. First is 6 to 9 months of BPAL, shorter oral regime. Second is shorter oral, that is 9 to 11 months of MDR RRTB regime. Third is longer oral, that is 18 to 20 months. And the fourth one is H monopoly DRTB regime, which is for 6 to 9 months. So this flow chart has been discussed many times, but what important thing is we are going to discuss about BPAL-M, shorter and longer. So what should be our preference when we are starting to treat the DRTB patient? So if the patient is eligible for BPAL-M, that will be our first priority. So if the patient is eligible for BPAL-M, we'll start the patient on that. If he is not eligible, then we'll start on shorter oral. And if he is not fitting in both the above criteria, it will be longer oral M or XDR regime. That must be clear. So now, sir has already covered this, that BPAL regime consists of bedaquiline, fetonamide, linezolid, and moxifloxacin. You can see how much pill burden is decreased in this slide. We can see that longer will be more than 14,000 pills in 18 months, whereas in 6 months, BPAL will be only less than 750 pills. So what are the inclusion criteria? So this is very important to remember. First is the patient must be more than 14 years and above. So if the patient is more than 14 years and above and new microbiologically confirmed MDR or RRTB. Now here we should also remember that if the patient is probable MDR-TB, that is if the patient is H mono or polydrug resistant TB in the failing regime, we can call it as probable MDR and they too can get the benefit of BPAL regime. Second, history of drug exposure. That is, it should be less than 1 month intake of all the 3 prime drugs, that is bedaquiline, linezolid, and fetonamide in the past. Or if the patient has received these drugs for more than a month, but it is documented sensitivity of these drugs, or if the patient has even received shorter or longer regime in the past and not failed that, and again shows the sensitivity of all these bedaquiline, linezolid, and fetonamide, patient can still fit into the criteria of BPAL. The QT interval in ECG should be less than 450 in males and 470 in females. The patient should not be pregnant. If pregnant, the duration should be less than 20 or 24 weeks and should be willing to do MTP. Patient should not be lactating, or if lactating, should be using non-formula feeds. So these are the inclusion criteria. Now, where we cannot give, that is exclusion criteria. If patient is less than 14 years of age, if there is documented resistance to bedaquiline, linezolid, and fetonamide, if the liver functions are more than 3 times, that is enzymes and bilirubin both, more than 3 times of upper limit of normal, if there is severe form of extrapulmonary tuberculosis like CNS TB, spinal, skeletal, or disseminated TB, and patient has cardiac conduction abnormality, then this patient excludes the criteria for starting BPAL-M regime. So if we go picturically, if the patient is more than 14 years of age, not have taken more than 1 month of the all three medicines, or it is sensitive if the QT interval is less than 450 in male and 470 in females, if the liver enzymes are not more than 3 times of normal range, upper limit of normal, patient should not be breastfeeding and should be using formula feeds, should not be pregnant, or if pregnant, less than 20 to 24 weeks of gestation and should be ready for MTP, and no severe form of extrapulmonary or no disseminated TB. So these are the inclusion and exclusion criteria for BPALM. Now, what are the doses? So 200, 400, 600, very easy to remember. Bedaquiline, initially 1 to 2 weeks we are giving, initially 2 weeks we are giving 400 milligram once daily, and then week 3 onwards it will be 200 milligrams 3 times a week. Petronomide is 200 milligram daily, linezolid is 600 milligram daily, and moxifloxacin is 400 milligram daily. Now, there are no weight bands for this regimen, and all the patients of above 14 years will be given same dose. Pyridoxine should be added to prevent peripheral neuropathy. Now, important points to remember that if the patient can't tolerate linezolid for 600 milligram because of severe any side effects or grade 3 neuropathy, then for at least for 9 weeks, then regimen is declared to be failed. Patient must tolerate linezolid of 600 milligram for first 9 weeks. Then the dose reduction of linezolid to 300 milligram can be considered after 9 weeks, but then the total regimen, all 3 drugs will be extended up to 39 weeks. Moxifloxacin is a part of BPALM regimen for full course, irrespective of resistant pattern to fluoroquinolone, even at baseline or during the full course of regimen. Since bedaquiline and linezolid regimen resistance level are low in India, it is recommended that initially, if the patient is eligible for BPAL, even in absence of drug sensitivity, we can start the BPAL-M regime in that. Now, second comes 9 to 11 months of shorter. The inclusion criteria for shorter TB regime is rifampicin resistance detected, but fluoroquinolone resistance not detected. There is no history of exposure to previous treatment with second-line drugs, or this for more than 1 month, or it is sensitive. There should be no extensive TB disease, no severe form of extrapulmonary TB like CNS TB, spinal skeletal TB, and same, patient should not be pregnant, non-lactating if we are going to use ethionamide. So it should be RR or MDR. There should be no fluoroquinolone resistance. Patient should not have taken the medicines for more than 1 month in the past, or it is shown to be sensitive. There should be no extensive or severe form of extrapulmonary TB. We can give it for kids more than 5 years of age, and patient should not be lactating when we are or pregnant when we are using ethionamide. Now, interesting point, and the regime, that new regime that this was the old where we were using ethionamide in the past. The new regime consists of linezolid. This is the new change which has come recently. So we can now use 2 months of linezolid, 4 to 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, and high dose INH, and 6 to 9 months of bedaquiline. This would be the starting phase. And later, for 5 months, we can use levofloxacin, clofazimine, pyrazinamide, and ethambutol. Now, when we have replaced ethionamide with linezolid, so it can also be given to pregnant women. So ethionamide cannot be given till 32 weeks of pregnancy, but linezolid can be, when we are using linezolid, it can still be given to pregnant women. Second, thyroid function test is not required in pre-treatment evaluation because now we are using linezolid. And it can be given in both cases. Now, previous guidelines, we had the guidelines where it was mentioned that if there is CAT-G and INH mutations both, we could not use ethionamide. But now, because we are using linezolid, we can use shorter regime even if there are both the mutations present. So this is the new change in the guidelines. Third one will be longer oral. So it consists of bedaquiline for 6 to 9 months, levofloxacin, linezolid, clofazimine, and cycloserine for 18 to 20 months.
Dr. Komal, we have about 2-3 minutes.
Yes, ma'am, I'm almost done. This is like third regime. So on patients who are who are not able to receive BPAL or shorter, in whom we will be starting longer. And we must remember that for XDR-TB patients, the duration of longer will be 20 months. So how do we select? We have to give all 3 group A drugs, that is levoflox, linezolid and bedaquiline. At least 1 drug from group B, that is cycloserine or clofazimine. So that should consist of 5 drugs. And when bedaquiline is stopped, we can continue using 3 drugs. So if only 1 or 2 group A agents are used, both group B agents must be included. Finally, the last one, that is 6 to 9 months of H monopoly drug resistant regime. So here we are replacing isoniazid with levofloxacin. There are no separate IP or CP, and it can be extended up to 9 months in selected cases. So this is a little in detail. Now, failing H mono and poly DRTB regime can be labeled as probable MDR case. And here we must again check if the patient is eligible for BPAL, we'll give that first. If not eligible, we'll look if the patient can be given shorter oral. And if not both of them, then we'll take him, consider him as longer oral. So what we learned today is about BPAL regime, the inclusion criteria, exclusion criteria, the shorter oral, the longer oral, and H monopoly regime. Still confusing? Then we have the great guidelines that were published in November 2024 by National TB Elimination Program. And if you have any doubts, you can mail me on this email ID. Thank you.
That was an amazing talk, Komal, and amazing presentation. We really need to learn from you youngsters how to present it so interestingly. Very well presented. So I think we have learned a lot of things now about the newer diagnostic, about the newer guidelines, what has been updation of the guidelines, the updated guidelines of November 2024, what has been the evidence we heard from Dr. Siva Kumar. And so now, how do we actually apply these guidelines or this understanding, knowledge in our clinical practice? Because when the patient is there in front of you and we have to apply these guidelines, that's where the real challenges come. So I think we start with the panel discussion. We have very exciting panel discussion, and our panelists for today's session are Dr. Kinjal Modi. He's MD Pulmonology, and he's also done his DNB. He's a consulting pulmonary physician. Not only he works in his private practice, but he is also, as a private-public partnership, he's also taking care of DRTB Center at Malad. He's also attached to PD Hinduja Hospital, Khar. And he, as you can see here, he's, achieved a lot of research papers and a lot of awards. And recently, I think he's completed his LLB and recently been awarded the LLB degree. So I think Dr. Kinjal Modi. The next panelist is Dr. Gyanshankar Mishra. He's an associate professor on respiratory medicine at Indira Gandhi Government Medical College, Nagpur, with 15 years of experience, and is also fellow of National College of Chest Physician. And he's also had a number of publications to his credit and book chapters. So welcome, Dr. Gyaneshwar, and thank you for accepting our invitation, Dr. Kinjal and Dr. Gyaneshwar both. And our third panelist is Dr. Narayan Pradeep. He's graduated from AI Amin Medical College, Bijapur, Karnataka. He's worked as registered in CMC Vellore. He's also member and scientific committee of 4th National Seminar based on integrated medicine. He's also secretary of Mangalore Chess Association, and he's presently a secretary of Kasargod Chest Society. He has got 12 peer-reviewed publication in Index Journal, and he's now taking care of District DRTB Center as a junior consultant in respiratory medicine, working with the government of Kerala. So welcome, Dr. Narayan Pradeep. I welcome all the panelists, and let us start with our panel discussion. So I think if we can highlight the panelists and as they answer, I'll start with Dr. Gyanshankar. So, Dr. Gyan, we heard the talks today about the new regimens available, the diagnostic algorithm, and all that. But actually, in your TB, in your practice, when the patient comes in front of you, how do you apply the checklist to actually decide which regimen you are going to give it to the patient?
Thank you, madam, for the question. Basically, as of now, BPAL-M regime is yet to be rolled out in Nagpur. So, as per the algorithm, once it is rolled out, when a new patient comes, so essentially this will be the first choice regime. So, if we have a new patient, more than 14 years of age, non-pregnant, then this should be the first choice. The patient should not have any liver or abnormalities. Again, if the patient is not eligible for this regime, then the next choice will be the shorter regime. So let's say if we have a patient who is pregnant or lactating, so there the first choice regime will be a new shorter regime. Pyramid is not there. And again, one important point is the severity of the disease. Currently, the BPAL-M regime can be given to severe pulmonary diseases, but not to severe extrapulmonary diseases. However, the shorter regime, the new shorter regime, they are both severe pulmonary and extrapulmonary. Both of them are contraindications. And if the patient is not eligible for any of these regimes, then we fall back to the conventional all or longer BDQ-based regime. But in practice, one of the drawbacks of the shorter regime is that we require LPA. And the LPA turnaround time in field, it is quite high. So I personally practice that if I do not have an LPA, I will not go for the shorter regime. Instead, I will shift the patient to all or a longer regime. Thank you.
Excellent. I agree with you, Dr. Gyanshankar there, because even in Mumbai, we see that patients, we have very high incidence of FQ resistance, almost to the tune of 60 to 65%. And still at field level, there is a challenge of having a LPA test available when the patient presents to us in the OPD for the first time. So I would say very few percentage of our patient actually get started on the shorter regimen. But now with BPAL regimen being rolled out, I think definitely our first preference is going to be BPAL, and especially because it's allowed in extensive pulmonary disease. Though I have my own apprehensions about using it in extensive pulmonary diseases, but all the data says that it is showing, and even our own data, Indian data is also showing that there are good results, good conversion rate, and lower relapse rate in patients with extensive pulmonary disease. So I think the choice is going to be more between BPAL-M and all oral longer regimen, taking into consideration all the factors. I think the next question also I'll ask to Dr. Gyan, because probably he has some assignments and he might have to leave early. So what are the most challenging ADRs, adverse drug reaction, you see in DRTB patients in your practice, and how do you address them?
Right. So for this, we had recently done this ambispection study. In that, we found that the top 3 areas where the number 1 was clofazimine-associated skin discoloration. Number 2 was linezolid as associated this peripheral neuropathy. Number 3 was surprisingly arthralgia associated with FQs. So all of them have their own challenges. Like this clofa-associated skin discoloration, it does not have any pharmacological cure established in our allopathy. So the only choice is good counseling at the start of the treatment, and you need the reassurance because this is just a purely cosmetic ADR. But this can be challenging, especially psychological trauma can be there to young unmarried females. Number 2 is linezolid associated peripheral neuropathy. So here our researchers showed that almost 43% of the patients on this DRTB regimes, they had this peripheral neuropathy. Early recognition is very important. So you need to recognize it early, and then the steps are either a dose reduction or dose modification. If not, then you need to give symptomatic treatment. Maybe amitriptyline, nortriptyline, pregabalin, gabapentin, methylcobalamin. These are all the options, but none of them will give perfect cure. Means established cure is not there. So now in BPAL-M, the challenge is that in the initial line mix, you cannot do dose reduction or dose modification because then the patient will have to be shifted to other regimes. So this was the peripheral neuropathy, and lastly it was arthralgia. In arthralgia, what we have seen is that the FQs are the most culprit drugs, and surprisingly, levoflox is shown to have more arthralgias compared to moxiflox in our studies. So plain NSAIDs and sometimes dose reductions. If the patient is on the lower side of the weight band, we shift to a lower weight band. So that's how we address the challenging areas in our practice.
Okay. So I'm sure there are many more other areas that we see, but the commonest, I would agree with you, is the peripheral neuropathy and CLOPA-induced discoloration. And I think QT prolongation also, when they are using multiple other drugs, can be a challenge. But compared to what was earlier, apprehensions were there that bedaquiline is going to cause a lot of cardiotoxicity, but we see that probably bedaquiline is one of the safest drugs to be used. And we hardly ever, in my practice, I've hardly ever had to stop the bedaquiline. So I think probably that's a very safe drug to use. So many times we have to choose to extend the duration of bedaquiline because other drugs are causing a lot of toxicity. So thank you, Dr. Gyanshankar, for all your inputs. And now coming to Dr. Kinjal. Dr. Kinjal, we've had now a lot of updation of guidelines and newer diagnostic tests are available, but still we face a lot of challenges in private as well as public sector. So I would like to know from you, what are the diagnostic challenges you face in the public sector and in private sector? Since you have the privilege of working in both sectors, I would like to have your inputs on this. Dr.
Thank you so
Kinjal.
much, Alpa madam, for that question. Am I audible, ma'am?
Yes.
Yes. And I'd like to thank ICS also for having this kind of interactive conferences and webinars every time here and there. So basically, people are getting more and more knowledge about the new regimes and the new treatment which is coming up for TB. Madam, basically, it's two worlds altogether. When we work in the private as well as public, I work in both the settings, so I know where to work from. I was just trying to get one of the some similar condition. So I remember the Chava movie. So when he was attacked at that time, so I remember that we had many weapons to fight with. So that happens when we are in the private sector. We have many things at our disposal. So many things we can use up. And when unfortunately go to private sector, our hands are tied up. So that's basically because of cost issues coming to the picture. You don't have much of the access to the what do you call the investigation.
Newer drugs.
Yeah. So basically, coming to the specification, madam, when we go to private sector, people want more accurate and timely treatment. Time is the crux. People want that basically we want the as early as possible we can spend, but want the diagnosis at the earliest. So then we have many drugs and many things available, many investigations available with us, like Gene Expert, LPA, parasequencing, cultures, lot many things, WGS. So now we have to think ourselves what is the best for the patient compared to where the DB is, extrapulmonary, pulmonary. Depending on that, we have to get the samples accordingly and get it done for the best labs available, so that basically the patient is treated at the earliest and the best treatment regimen is available for the patient, because they are affording, they can start as well. Video nowadays available in private sector also. Many people doesn't want to just go to public sector for the getting the medicines nowadays. They start the medications on their own. We just have to refer have a Nishchay ID number for them. So that is the private part of it. Next, the public sector. Now the things comes.
Can you come a bit closer and talk, Dr. Kinjal? Some of your words are getting lost, I think.
Extremely sorry, ma'am. I was audible that time, or should I repeat the things?
Yeah, no. It was audible.
Oh, so basically, sorry for that audible issues. So in the public sector, things are a bit different. Now, when you come to this picture, this kind of a place, we have but tight constraint regarding the cost, because patients are not going to spend for their own pockets. So we have to depend only on the government setting what are available. Though government is trying very hard. I've seen for last decade I'm with government. I've seen the whole paradigm change in what the system was there 10 years back and now. So fantastic, government is working very hard for this settings. But things, few things are here and there are there which they are trying to fix, because getting the report traced is very difficult. Yesterday only I had one training session in which it was very, very nicely stressed that we start the treatment, but the reports are coming bit later. So patient is getting treatment bit later. All those things do happen. So public sector has its own benefits because medicine is getting free of cost. Patient is happy. Many times NGO get tied up with the government patient very easily. They get nutrition benefit also over there. But there the cost is an issue. So basically time can be delayed in that cases, because many times I don't want to delay the time, but sometimes it get delayed. Is what I feel as a drawback.
Okay. Yes, thank you. So you highlighted the challenges very well. I think in the private sector, the problem is that uniformity of the guidelines are not followed. So that is one thing we need to,
every person thinks that he is the boss. Yeah, he thinks that he is the boss and he gives a treatment on his own.
So that's what I think is a challenge, that we need to make our clinicians aware of the guidelines and the guidelines to be followed. While in public sector, the availability of the test, the affordability of part because if the tests are not available, especially in extrapulmonary tuberculosis, then becomes a challenge. And timely availability of the test result becomes a challenge. So, thank you, Dr. Kinjal. So now my next question is to Dr. RADHA MUNJE, madam. So
Yes.
patients with extensive pulmonary TB, now according to the new guidelines, we can initiate them on BPAL-M regimen, but many clinicians have expressed this apprehension that how comfortable one would be about introducing BPAL-M in extensive pulmonary disease. So I would like to know, Dr. Radha, your experience and your views on it.
Yes. Let me be very honest, Alpa. We are yet to get the BPAL regime here. So I can't claim that I have a first-hand experience with that. But yes, when we look at the guidelines, we know that when we talk about even the shorter MDR regimes, if you have extensively, I mean, serious forms of extrapulmonary TB or extensive disease pulmonary, then you do not offer them shorter regime, but you prefer to give all oral longer regime, right? Similarly, about in BPAL also, for serious forms of extrapulmonary or those with complications, BPAL-M is not being offered. However, the guidelines say that you can give it to extensive pulmonary disease. Since I haven't used, I can't make a very dogmatic comment on this, but I would still be really apprehensive, at least till I get some experience of initial few cases being treated. And of course, all these patients who have extensive disease, we have to keep in mind that they are likely to have not only a larger burden of bacillary load, but also mixed population. And hence, even if they are offered BPAL-M, I think very close vigilance on response to treatment or emerging of drug resistance in between has to be kept in mind. If at all you offer BPAL-M to extensive pulmonary disease.
Thank you for that input. In fact, recently for TB oration in Mumbai, I had opportunity to interact with Dr. Kirtan Deda from South Africa, and he's done extensive research work. He's been part of this BPAL regimen studies also. So he also had expressed his apprehension that in patients with extensive disease, he would rather tend to start them on all oral longer regimen. But his own experience, he did say that people with extensive lung disease have also done well with BPAL regimen. That is what has been our Indian data also saying that people with extensive disease have done well with BPAL-M regimen. So well, we hope, I think in this group of patients, we should be able to use them successfully with a very, with vigilance and frequent monitoring of these patients. So my next question is to Dr. Pradeep. Okay. So what are the challenges at field level in diagnosis, treatment and follow-up of DRTB patients? Because all of us face these challenges at field levels, and implementing the guidelines as they are given is always a challenge in field level. So I would like to know it from you.
It is challenging right from the diagnosis, because even to get the sputum also it is very difficult for the cultures. They tell we are not getting sputum, number one. Number two is transportation of the patients from the to the district TB centers, maybe 20 kilometers, 30 kilometers. Okay, in our place, like the smaller districts, smaller areas, it is possible, but still we are having issues. Number three is they are once they are diagnosed, the stigma is still there with the TB, especially with MDR. They are losing their jobs, losing their earnings, and they are isolated. And number fourth is like when we start the DSTB regimen, and they have slightly improved clinical symptoms. When the report of DRTB comes, culture report, then they suddenly ask why this drug is working, why you want to change the drugs. And unfortunately, many of the patients will develop ADRs with the DRTB drugs. Then they will tell, the earlier drugs are very good, now drugs are they are causing more problems. So these are all the major things. Then the follow-up, we are very vigilant that at least we are visiting their homes. Our health workers are going to their homes. Then we are able to get them more than 80%, 80 to 90%, we are able to complete the treatment successfully.
Okay. Thank you so much for that input. And yes, we do face these challenges at field level, and as far as possible, try to overcome them, try to improve our systems, and give better results to our patients in public sector. So my next question would be to Dr. Siva Kumar. Uh, what are the advantages and limitation of targeted next generation sequencing? And do you think this will become the game changer in DRTB management in near future?
Thanks for the question, ma'am. So if you look at targeted next generation sequencing, although it's a newer technology and we think that sequencing are costly, it was a time when the sequencing was really costly 10 years back, where one genome of mycobacterium will cost you around 1 lakh. But now, if you look at the price and the technologies which is available, it has come down to around uh, 4,000 to 5,000 for genome, which is quite equal to a phenotypic test for all these drugs. So if you look at the technology as such, yes, it has become affordable. And if you look at developing newer diagnostics for drugs for which are not available, like for rifampicin you have, INH you have, fluoroquinol you have, but then you don't have for pyrazinamide for quite a long time, ethambutol no for quite a long time. The reason behind this is the mutations which are there are not specified in a particular position, or it is not concentrated in one region. For rifampicin, it is concentrated in one region. So if it is like that, you can develop a rapid diagnostics much easier. But for most of the antibiotics which are coming now, the newer antibiotics as well as the older ones like pyrazinamide, it is not like that. It is spread throughout the genome. So it becomes very difficult to develop a rapid diagnostic test. So TNGS or WGS is the choice, but then TNGS takes over WGS because TNGS can be done on sputum sample. And on follow-up, if a patient is failure, also if you do the TNGS and give drug susceptibility testing, it will be easier for a patient who is failing BPAL also to put him in a different regimen. Yeah, I definitely see TNGS as a game changer for DRTB diagnostics, but then we have to wait for the newer drugs. The catalogs have to be developed so that we are sure of the mutations which we report, which are resistance, rather than some company says one mutation, he identifies some mutation and says it is resistant, and we lose the drug. I mean, we cannot use that drug, right? So that shouldn't be happening. It should be validated enough before it goes into the program. Thank you, ma'am.
Yes, I think that's a very excellent insight, and this is what been happening when the WGS started. All different companies just came out, and clinicians started thinking, oh, we have found a magic solution for getting sensitivity patterns, and then we saw that it wasn't really matching with the phenotypic or with our clinical suspicion also. So I think that's very important. We have to wait for the validation, and I hope sooner than later it will come from ICMR, and we would be able to do this in a much. So currently it is being done as a research project at Chennai, your center.
Yes. So we do report as well for the drugs for which we are sure of. Like most of the drugs we are sure of, except for the newer drugs. So yeah.
So which drugs you are not sure of?
Mostly now it is only pretenamide and delaminid. Rest of them gives good amount of sensitivity. At least it tells you to rule in resistance rather than rule out resistance. Rule in resistance and start using changing the drug or anything. Because phenotypic test will be available in another 1.5 months or 2 months maximum.
Okay. Thank you so much for this. So my next question is to Dr. Komal. In your practice, which complications for DRTB patient require ICU admission, and what are the challenges?
Thank you, ma'am, for the question. And we do see patients in the ICU or DRTB patients requiring ICU. That is, like, I would like to divide it in 3 groups. One is specifically related to TB itself. Like if the patient develops septic shock, ARDS, can lead to extensive infection. They can also get secondary infections, fungal infections, specifically in patients who are HIV, TB co-infections. Then PCP and other infections are there. These patients end in ICU. Second, due to structural complications like pneumothorax, like empyema, they can again land up in the ICU. And we should not forget about the drug side effects, like the side effects of drug, extensive hepatitis, then peripheral neuropathy. So those patients also end up in the ICU. The most challenging thing when the patient of TB comes in the ICU is about the isolation. So we don't have that much of uh, manpower also in the ICU, where we have to, then it becomes very difficult to keep the patients in the ICU, give them separate nurses and all. Then there are drug interactions when we are going to give other drugs, then we are giving already MDR-TB drugs. So that is also one challenge. Then if there is electrolyte imbalance, and then again we are giving drugs which are prolonging QTs. So that will be an issue. Plus, these patients, if they go in the ICU, they have a lot of psychological burden, because they are already DRTB patients who are fighting against the infections very hard. So these are the challenges which we
Yes.
see.
So I
And
agree
plus,
with you. I
if
think, yeah.
if the patients require mechanical ventilation, then again it becomes all the more difficult. We need to have that negative suction available and all things which are hardly available. So it
And
becomes very
unfortunately, we don't have such a good setup in public sector where
yes.
patient can be managed in the ICU. Okay. So, okay, thank you, Dr. Komal, for your inputs. My next question is to Dr. Kinjal. What is the role of pyrosequencing in diagnosis of pulmonary TB and EPTB?
Ma'am, nice question. Basically, it's a new weapon we have got basically in the TB diagnosis nowadays. It's a basically rapid the DNA sequencing test, like a PCR kind of a thing. The thing is, it's giving us an idea of the diagnosis of TB as well as resistance pattern of first line, second line, both. But only thing is, see, as a Hinduja, we have all the things available to us at disposal. But many times I speak with Dr. Camilla Rodriguez, madam herself. Uh, for the EPTP samples like CSF and all those things, basically when we are not getting anything in the cultures, parasequencings do give something, at least an idea in that. Gene expression negative, parasequencings do come positive in those cases. It is good. But definitely depending on the resistance to the phenotypical DST what we get is not always true. So we have to take a pinch of salt always in the initial part, because we can report in 2 or 3 days maximum. So it's great to start the therapy, but please always correlate it with the DST pattern which comes later.
So I think initially we used to use pyrosequencing more exclusively for CSF sample, but of late we have started using it for other samples, and I have found excellent result. Like we recently used in a BAL sample where this gene expert showed a trace. We used it in biopsy samples, and we also used it in a pus sample from EBUS. So I think we should probably start using pyrosequencing more often in not only CSF but other fluids, as well as BAL sample, sputum sample, and also pus
All the
aspirate
fluids, ma'am. All
from.
the fluids. It's very good for all the fluids, madam. The only problem is that basically remember the DST pattern. That basically does not 100% correlate with the
Yes, but
phenotypic.
sometimes when there's a diagnostic difficulty between
Definitely,
TB or
it's
not
very
TB,
helps.
then
Yeah,
at least, yeah,
very
at
helpful
least
in the
it can.
diagnosis of TB. Perfectly nice test, ma'am. CSF many times we miss out things, and we get the diagnosis with parasequence, ma'am. Really good.
Okay. Thank you, Dr. Kinjal. So my next question is to Dr. Pradeep. How often do you give bedaquiline extension to your patients, and under what conditions you give bedaquiline extension?
Yes, ma'am. Thank you, madam. Earlier it was very rare, but now the newer changes is that even in the shorter oral regimen, at the end of the 4th month, if sputum smear is positive, we can that is end IP. If it is IP is extended, then in that case also we can extend the bedaquiline, but it should not be more than 20 months. 20 and another 20 things. So there is one case. Then if in regimen, if group A and group B, if you are not able to put because of the resistance patterns, then in that case also we can extend the bedaquiline.
So I think two situations where when a drug goes away because of ADR or
Yes.
because of resistance pattern, then we might have to extend the bedaquiline. Also, if patients have been previously treated or patient has got extensive disease and we have limited number of options available, in that situation also we go for bedaquiline extension. I think that's a very important message to get, that under the situation where a drug is lost because of either ADR or being resistant, I think bedaquiline extension should be given. That is one of the best drugs to be given, much well tolerated and with lesser ADRs and very effective. Because sometimes the replacement like ethionamide or PAS is given in this patient and they are unable to tolerate it. Instead of that, it's better to give bedaquiline extension. And thankfully now the program, we have provisions of giving bedaquiline extension and it's available.
Can I ask something, ma'am?
Yes, yes.
So, ma'am, have you seen bedaquiline resistance as well? And how frequent, like?
What resistance?
Bedaquiline resistance.
Yes, so Dr. Siva Kumar has shown the data. So in patients who are exposed, we have seen higher bedaquiline resistance. Our data also, Dr. Singla's data says about 26%. But overall, patients who are not exposed, then it's less than 2%.
And these are MDR patients, not on DSTB.
Yes.
DSTB patients, if you look at it's less than 0.1%.
Yes. So, is Dr. Gyan still there? No. Okay. Okay. Yes, Dr. Gyan, I just wanted to ask, do you have a thoracic surgery department in your hospital? And now with the newer regimens available, are you requiring surgery much less often? And which are the cases where you refer them for thoracic surgery?
So as of now, we do not have a dedicated CVTS department in our college, but we do have a general surgery department. It does most of the thoracic surgeries. And for complex cases, we have linked up with the thoracic surgery department at super specialty government hospital. So we do refer to them. With the new BDQ based regimes, this cure rate has definitely increased and it's quite high. I can hardly remember any patient who has failed this regime in the last 2 to 3 years. So definitely surgery referrals, they have decreased. And the patients who are referred for surgery, those are basically the ones who have localized disease and unilateral disease. So in localized and unilateral disease, if the patient is not responding to therapy, the guidelines PMDT 2021, they say that 6 to 9 months of therapy, if the patient is not responding, then they can be considered in localized unilateral disease. Then patients where we are not able to formulate an effective regime and where the disease is localized. So those could be one subgroup of patients. Then coming to non-healing BPF, empymas, those are the ones. And then we come to next subgroup of patients, which is the post-TB sequelae, where the TB has been treated, but the patient has recurrent infections, symptoms like hemoptysis, recurrent infections. So there we do refer them. However, the one point is important when referring these patients, that we should assess for core-pulmonary or pulmonary artery hypertension, because then the post-operative complications will be very high.
Can I add something here, Alpa?
Yes, sure, madam.
Whenever these patients of MDR are being referred for surgery or has come out of surgery, it's very important to remember that anti-TB cover has to be continued, because there is a lot of handling of tissue. You do not know how much spillage has occurred, or has there been any silent lesions which were not seen on X-ray, because usually the follow-up is by X-ray, though a CT is always done before a surgery is taken. So it's important that pre-surgery patient receives proper treatment for at least 4 to 6 months, trying to make the area as sterile as possible, then surgery, and of course continue treatment till the outcome is declared.
Yes, right. I think that's a very important point. And also sometimes non-resectional surgery can also be offered at time. Patient with extensive but limited disease, we have done a limited thoracoplasty to close a cavity. Now, in desperate situations, we have done that, and window surgeries for empyema, tuberculous empyema, and bronchopleural fistula. So these are also things we do it, and fortunately now we are needing them lesser than what we used to need before,
Yes,
and
definitely.
hopefully we won't need them more in the future. So I think we've had really excellent discussion, and thank you all the panelists for all the inputs. And I think now a lot of audience questions are there, and we would take some of the questions now from the audience. So, so one of the question coming from Gopal Singh Solanki from Maharashtra is if there is clinico radiological non-improvement in H mono or poly DRTB patients after H mono poly DRTB regimen is there. So any provision for BPAL M like regimen in these patients? Radha madam, would you like to take this questions?
It won't be applying, madam. Just to tell very frankly, upfront, it won't be applied, madam, because if the patient is on medications which are exposed to means bedaquiline, everything has been given for at least 1 month, then basically they are not.
No, they are
It
saying
are
H mono
still
resistance.
applicable.
H mono resistance, they
That's what I
will.
do.
Yes.
And they can be considered as the probable MDR, and they are eligible for all the three regimens, like BPAL, shorter and longer. Depends. If the patient fits in BPAL, we'll start with BPAL, thinking that patient is probable MD.
I think I need to add something here, Alpa, that if
Yes.
patient is H mono and poly DRTB and not responding clinico-radiologically, that means we have to understand that there is some process of augmentation of drug resistance in this
Yes.
patient. So whatever drugs are being offered are not acting because of probably acquired drug resistance to these drugs. Whatever may have been the reason, compliance can be the issue, the drugs not reaching the tissue is there. Many things can be done. And I think here the attempt should be first made to look at the type of resistance that the patient has and then formulate the regime or offer the best possible regime to these patients.
Okay. Yes, so that's correct. So first, before anything, you're supposed to confirm that the augmentation of resistance is not there. That's very important. And once you have confirmed that the augmentation of resistance is not there and patient is still not responding, calling it a clinical failure, and then maybe you could consider these regimens. So I think first that attempt has to be made to see that the augmentation of resistance has not happened. So, Dr. Tridip Chatterjee from Mumbai, he said BPAL for XCR, isn't that the latest? And BPAL M for MDR, isn't that the latest? When do you exclude patients from this for older, longer regimen? I think we've already discussed that, but still, I think Dr. Komal or Dr. Munje, would you like to take this question? So I think for BPAL XDR and BPAL M for MDR, that is not how it is there. BPAL M you give irrespective of whether it is MDR or XDR, and M is included irrespective of the sensitivity pattern. And so when do you exclude patient from this for older regimens? So I think we've had this discussion, but Dr. Komal or Dr. Radha madam, you can take this.
So exclude from what, ma'am? Exclude from BPAL?
So when do you exclude them from BPAL M and put them on all oral longer regimen is what
So
Dr.
the exclusion criteria.
See, let me add,
Okay.
Komal.
Yes, sir.
Dr. Tridip, let us understand that we have very well-defined inclusion-exclusion criteria for BPAL M, right? So all those who do not fit into BPAL can be offered either shorter oral or the longer regime of 18 months, that is bedaquiline based, right? So that is, I think, as simple as we can make that you look at the inclusion exclusion criteria which have been well defined and then offer regimes accordingly. And whereas BPAL and BPAL M doesn't exist in our country, it is always BPAL M for all practical purposes for MDR or XDR who have not been exposed to these drugs for more than 1 month.
Right, ma'am. That's true.
Okay. I think one of the question was what are the most effective infection control measures, but with Dr. Gyanshankar Mishra has already answered.
But that would not be visible to the audience.
Huh?
That will not be visible to the audience.
Oh yeah, okay. Those.
Certainly, I have to answer them
I
again.
think let's first take the clinical question. Then, if we have time, then we'll say.
Yes.
Okay. What drug therapy can be given for MDR prophylactic like INH and rifampicin, rifapentin INH for DSTB? So, what preventive therapy can be given for DSTB?
For DST, ma'am, that both the things are available. One is 6H, basically, or 9H, what early people used to give.
6H,
And now we have
3HR,
3 HP. Now we have 3 HP
and
basically.
even 1 HP we
And
have.
1 HP is also basically is going to miss. It can be, it is a good trial has been done and very good results are there. But actually for my personal impression is that person we are preventing a TB. So we prevent resistance also simultaneously. So why to expose a patient for rifampicin who we are just preventing a TB? So H is okay. This is what my personal belief. Giving a HP either 3 or 1 is better. Okay.
So I think quite a few number of our patients deserve this latent TB treatment.
Definitely.
Patients who are immunocompromised, patients who are, we see a lot of rheumatology patients who are going to be put on immunosuppressant, on rituximab, patients with organ transplant, patients who are going to be getting transplanted. Now, these are a group of patients where definitely, and what I have seen that patients are happier with once a weekly regimen of 900 milligram of isoniazid and rifapentin. So I think that's we have to be selective. I also agree that not all patients we are going to treat with all the exposed contact, but at least patients who are high risk for development of TB, we should be treating them with preventive therapy.
Ma'am, I think they are asking for DRTB prophylaxis.
Yeah, that is also a question. I think who would like to take that question? What prophylaxis you use for DRTB contacts, especially high risk contacts?
It is one of the guidelines earlier mentioned 6 months of levofloxacin, but
yes,
present
it was
guidelines doesn't
mentioned.
mention. Earlier it was mentioned, now this present guidelines is removed, madam. So I cannot be commenting on that, but earlier it was there.
I think the best prophylaxis that you can give is the nutrition, and now that ration trial has proven
Yes.
that family members whose nutrition was taken care of, there was 40% reduction in the incidence of DRTB. So I
That was
think
mother style one. That was true. Means basically mother style is proven a century ago. That basically if you get good nutrition, good immunity, you don't get TB even if your family has a index case is there in your family.
And that is the best vaccine available till date.
absolutely that's the best vaccine, and that is often underutilized, I would say, and overlooked.
That's true, ma'am.
Yes. So, what are the current challenges? What are the current challenges in and gaps in DRTB surveillance and reporting?
Various gaps, madam. Basically, I was trying to tell that only in my initial part of the talk that unfortunately gaps do exist because we get a gene expert report today. LP is pending for next 2-3. Generally should have come in 2 or 3 days, but generally comes in 2 or 3 weeks. And the culture DST should have been come within at least 2 to 3. Within either a month's time, but generally come up to 3 months. So delay definitely occurs at the level of getting the reports to the clinician to treat the patient in public sector. In private sector, is a different ballgame altogether. But yeah, there is a lag in that which needs to be fastened as early as possible.
Okay. I think then the question for prophylaxis was for DRTB, but I think that is also answered. I hope you got the answer. Dr. Tridip Chatterjee is asking pyro sequencing, is it validated in BAL? So yes, it is validated and we've been using it. Okay. What are the implications of using whole genome sequencing for DRTB diagnosis and surveillance? I think probably it is also been covered in the panel discussion as well as in the talks also. Then there is a question, what are the latest development in rapid diagnostic tests for DRTB such as Gene Expert and next generation sequencing? So I think this has also been answered. Dr. Siva Kumar, would you like to add something to what is already?
Yes.
So
The answer to this rapid development in rapid diagnostic is that when we get that 10 colored cartridge at one go in one sitting and with a turnaround time of not more than 2 hours, one would be getting to know about INH resistance, fluoroquinolone resistance, as well as rifampicin resistance. So what information you get by LPA, that is taken care of by gene expert XDR cartridges. And I think that is one of the best developments that we have. And it's not only the gene expert, but many other companies have already come up with this chip-based diagnosis, which are under validation at ICMR. Dr. Siva, you should be able to add
Dr.
more.
Siva, yeah, let him say, that's true.
He
Yeah.
must be
So,
having n number of such tests for validation now.
Yeah, yes. Recently, if you see, there was, I mean, earlier India was not that much interested in innovations probably in
Yes.
TB. But then now, recently, a week back, there was India TB Summit. In that we had
Yes.
around 200 new tests, cartridge based, chip based, and other tests which could answer all these questions in terms
Yes.
of rifampicin, INH, and fluoroquinolone. And you can classify the treatment into DRTB treatment or DSTB treatment. In the field itself, you don't have to transport the sample for LPA and things like that. So those are going to come. But then what is available is PathoDetect, which is already approved by NTEP, which will tell you about rifampicin as well as INH resistance, which covers most of our population except for the ones which are R resistance, which is around 3 to 10%. Yeah, those can be sent. So apart from that, next generation sequencing, targeted next generation sequencing is going to come with no time. Everybody is working towards it. So that will be the next thing which would be for DRTB diagnosis. Thank you.
So there was some other question. Can we consider BPAL-M regimen in pre-XDR TB? Yes, of course you can consider. Yes. So best approach for treating neuropathy occurring due to linezolid. And okay. So best approach for treating linezolid induced neuropathy. Any of the panelists can take this. So already we have discussed. So actually, the best approach I would say is detecting it early.
Yes,
that is the most important thing, because many a time in the field condition it gets missed. So regular at every follow-up the screening should be done. Symptoms like just simple numbness or burning sensation, pricking sensation, paresthesia, all those have to be asked and screened. And sometimes, we see this typically in young girls who are low BMI. This is very common to see linezolid induced toxicity. So sometimes in these patients, even before they develop symptoms, I get the NCV studies done. Right. So picking them early is the best thing. The moment you realize that they have symptoms, probably I think stopping the drug for a time period, maybe up to a month, and then starting the treatment, and maybe you can reintroduce at a half dose. So that is what is very important.
And other two groups are seropositive and the alcoholic patient, ma'am. These two groups are high risk for this condition.
High risk patient.
And ma'am, in 2024 guidelines, they have given very well detailed measurements and how about peripheral neuropathy, grade 1, 2, 3, 4, how to diagnose, and what pregabalin, where to add, when to add, how to add. So it is very much given in detail in 24 guidelines now.
Yes. There is one question: what nutrition would you suggest?
Yeah, I saw that question. Someone from Pune asked that question.
Everybody knows that we insist on high protein diet, and we have to understand that this insistence on high protein diet is not only for the patient but for the whole family. One. Secondly, whenever the nutritional baskets are prepared, we do not. I don't know whether I should be speaking it so bluntly, but we do not advocate or ask people to buy OTC products of high protein. because we know they have, it's not about, I'm not talking about the efficacy, because they are already fortified with micronutrients and other supplemental elements, but the cost is too high for that. So what we advise is dietary protein supplementations. So they should be taking a high protein. They can take and usually
Calories
what I
also.
advise, yes, calories and fat should also be added to that. So what I usually advise my patient is like, instead of taking only peanut and jaggery chickpea, if that is fortified with the dalia also added. So dalia, which gives sattu in other form if powder,
Right.
this is a very good supplementation. So I ask them to make it at home and add a spoonful of ghee to that while preparing. If there is no ghee, they can even add oil to it and then prepare them, and that is what the granola bars they can prepare at home, rather than going for costly dry fruits, which we know may not be affordable, and they would be needing to pinch on the other regular diet. So all this is in addition to routine diet which they should be having, like daily meals
Just one.
should not be compromised for proteins.
Sure. Just want to add one more thing, madam. Radha madam has said for fantastically the daily available things and for the public sector's things. But many times in the private sector, people do ask what to buy, how to buy, concept protein powder lay, because they are aware of various protein available, because advertisement are there, like Protein X is advertised by Akshay Kumar and all those things. So basically, people are aware of protein powders nowadays. So one simple advice is that always look at the nutrition table behind that dabba what you are buying, because many times I've seen even branded products, they are only giving 18 grams per 100 grams of protein. So 18 grams of protein per 100 grams of the content. So don't get misled by all those advertisements. Always see the dabba, at least 30-40 grams of protein per 100 gram is a better things when you buy this kind of products. And protein bars, nowadays protein cookies, all these things are also available when we are dealing with children. So that is also one more thing to get them all about. And one most important thing which is always, if a patient is non-veg or vegetarian, then eggs are the best bioavailable proteins available on the earth. So basically, if they can consume eggs, fantastic, nothing like that. But it has to be all the things together. It cannot be one. We cannot rely on one product like that. So many things has to be added now.
And I think vitamin D supplement should be added because many of our
Definitely.
patients are vitamin D deficient and it's too expensive to check for them. So I think micronutrients, and in fact, nutritional assessment should be an important part of our clinical assessment of this patient. But this time, NAPCON in the workshop of TB workshop, we included one entire workstation on nutrition.
Right.
I think we should have one session here on ICS webinar session on nutrition. So very important. So I think just last question. So there's a question about management of DRTB and special situation. So one is in pregnancy in HIV patients, and one more thing. So I think Radha madam, you can take on pregnancy, and Komal, you can take on HIV, and the third one I will just let you know.
Yes, the most important thing is we have different situations. So if there is a case of MDR TB and she's a young girl in a reproductive age group, the best thing we do is we counsel and ask them to practice contraception so that they do not get pregnant and does not hinder with the treatment of MDR. That is one part. If at all now a pregnant female is found to be MDR TB, then we counsel the patient, and if the pregnancy is of less than 20 weeks, then we can offer them counseling as and advise, if at all they are willing, they can go ahead with MTP and continue anti-TB treatment. Komal, correct me if I'm wrong about the weeks of pregnancy. And if the pregnancy is beyond that and you cannot terminate, but you cannot compromise giving regimes. So you have to choose the best possible regime, which will not be affecting the infant in utero, and offer treatment.
So now, ma'am, because we have linezolid in shorter regime in place of etunamide, so we can still give it in pregnant women, irrespective of the gestational age. But for BPAL, it should be less than 20 to 24 weeks, and patient should be willing to do MTP. and patient should not
What
be
we always say is we don't advise MTP. We give a good counseling and offer them, and then they make a wise
decision.
choice.
Yes. And patient should not be breastfeeding. They can use formula feed instead if they have already delivered.
Yes, and Komal, would you like to take an HIV and DRTB management?
Yeah. So we have many patients with HIV who have been treated with DRTB, and I would like to share one case where patient presented first at the HIV center, and then he was found to have cervical lymphadenopathy, miliary TB, and it turned out to be MDR. So this patient, he did excellent after starting longer treatment. But that time we had to start for longer for some reasons. Now, as far as the guidelines are concerned, HIV, all the HIV patients are eligible for BPAL also, shorter also, and longer also. Only we have to be careful when the CD4 count is less than 100 because they'll be having other infections as well. Second, most of the TLD, most commonly we are treating HIV patients with TLD medicines, and they do not interfere with our DRTB regimens. But if patient is receiving efavirenz, or I guess there is some another drug, efavirenz reduces the amount of bedaquiline. So we have to be very careful when they are using efavirenz. But if they are using TLD, then normal regimen can be given as BPAL, shorter or long.
Yes. So one more thing I would like to add is that liver monitoring for liver enzymes is very important because all the antiviral drugs, antiretroviral drugs, and AKT drugs, they are hepatotoxic, and QT prolongation also may be an issue, and iris. So these are three things.
Iris is very important. And ma'am, ritonavir also. Ritonavir increases the dose of bedaquiline. Yes, so when patient is receiving ritonavir, we have to check the levels of BDQ.
It's like there's one more thing to add over here, madam. Many times the patient, as Dr. Komal said very nicely, the patient first time came to ART center. So that the question arises, ART first or ATT first? So generally for the general public is always remember that ATT has to be started first generally, 15 days gap, and then ART has to be started.
Yes, absolutely. So I think we have really had excellent discussion and excellent participation by the audience and wonderful insights shared. And once again, thanking ICS for continuing this series of, academic feast, I would say. Thank you, Dr. Amita and Dr. Samaria, Dr. Sandeep Salvi for being the inspiration and giving us the platform to reach out to so many interested clinicians. And thank you all the participants for your excellent participation, and thank you all the faculty for giving your time and sharing your wisdom and experience.
Thank you so much. On behalf of our participants, thank you to you, madam. You have moderated the session very nicely.
And a wonderful moderator, Alpa.
Thank you, ma'am.
And we have had a very long webinar today. Wonderful. And still the questions are pouring in. Good one.